So I'm really excited that you came out tonight. Thank you so much for coming. I love my job, and I just would love to share that with you. And if you notice, there's a sign that says, please turn hearing aids to telecoil setting. There's a hearing loop, and you may not know what a hearing loop is, so I thought I would just tell you quickly. It's an assistive listening technology where this room has a wire going around, and so it's taking the signal from this microphone and putting it directly at the ear of anyone who's connected via telecoil on their hearing aids or an assistive device. So if you're still having difficulty hearing me from where you are seated in the room now that the microphone is working, I would encourage you to try out the hearing loop. And we just looped Flandros Science Center, the planetarium. Dr. Adamovich and I, it was lots of fun. And so if you're at Flandro and would like to use the loop, please check it out. So a little bit about me. How is your hearing? I'm an audiologist, so that's always what I like to ask. And I'm an assistant professor in speech, language, and hearing sciences, just like Tad described. And speech, language, and hearing sciences is found on the main campus. This is the view from the Dean's office of the College of Science. And here we are, speech and hearing right there. Beautiful place on campus. And we have a hearing clinic in our department. And just down the hall from the hearing clinic is my lab. And my lab is called the Listening in Multi-Source Environments Lab. And in that lab, we study hearing science and rehabilitative audiology. So we're combining the science of sound with the science of helping people. I need to acknowledge many, many people who I am so lucky to work with. It's just so exciting to come to work every day. I work with wonderful faculty in numerous departments on campus, including faculty on other campuses as well. I'm collaborating most closely with some faculty right now at Johns Hopkins. But we have a great big collaboration between audiology, speech-language pathology, public health, psychology, otolaryngology, and Spanish. And I'll be excited to tell you about that in just a minute. I also have the opportunity to work with many, many talented students at all levels. I'm the only faculty member in our department who teaches undergraduates, the master's students in speech-language pathology, and the audiology students in a given semester, I think. Dr. Beeson can check me on that. But many, many students have contributed countless hours to this work, and so I need to acknowledge them as well. And a couple of them are here tonight. I'd also like to acknowledge some special funding that we have in our department from the Pignatelli family. It's the James S. and Dyan Pignatelli Unisource Clinical Chair in Audiologic Rehabilitation for Adults. Quite a mouthful, but I'll tell you more about that as we go along as well. And this is a beautiful program that was funded by the Pignatelli family with the overall goal of improving the lives of adults with hearing loss and their communication partners. So they endowed a clinical chair in 2009 and offered continuous program funding for 10 years, and we're in the 6th year right now. And so I'm excited to tell you about that. As part of this program, we do many different things. There's a holistic orientation within the UA Hearing Clinic. We offer Living Well with Hearing Loss groups in English and Spanish. We conduct community education. We facilitate community partnerships related to hearing. We train students as well as professionals and do a lot of research in our spare time. Yeah. Most of the time, actually. So the University of Arizona team related to the Pignatelli program, I just wanted to highlight a few very special people. Dr. Fran Harris, who some of you may have met, just retired about a year ago, and she was the original chair of the Pignatelli program. Our groups are now facilitated by Dr. Stephanie Adamovich. Hi, Stephanie, you're out there. Hello. And she is available afterwards if you'd like to talk to her about one of our groups. Dr. Paige Beeson is our wonderful department head who provides really wonderful administrative support for the program. And Tom Muller is the coordinator of the hearing clinic. So a program like Living Well with Hearing Loss, once you have funding, the funding can just go nowhere unless you have the support of many people really driven to see it achieve success. And so I'm very fortunate to work with this wonderful team. So the overview tonight for our Science Cafe, as we sit down at the dinner table to talk about hearing, I'm going to address hearing loss as a public health issue. Then I'm going to tell you a bit about our current research, just a glimpse into 3 windows on our research. Our research in the lab setting, our research in the clinic setting, as well as our research in the community that Tad described for you in my bio. So let's start out by thinking about hearing loss and public health. So first, some questions. So just to get a little interactive here, I learned this trick at the science fair last week where you ask a question and then the audience responds by giving 2 claps. Clap, clap, okay? So I'll ask you a question and then I'd ask you to respond if you say yes with 2 claps. Should we give it a try? How many of you, good, thank you. How many of you are happy to be at tonight's Science Cafe? Woohoo! Excellent. Now, how many of you who are here tonight think that you have a hearing loss but aren't sure? A few claps. How many of you know that you have a hearing loss? Got like call and response going here. How many of you know someone else who has a hearing loss? Okay. I saw more vigorous clapping on that one. There were pointing happening. It was getting exciting out there. Now, is that someone else that you know a child? Okay. And is that someone else an adult? Okay. So what we're going to talk about next, viewing hearing loss as a public health issue, is hearing loss from the child perspective and hearing loss as an adult. Okay, so here's, massive grid, throw right up there. This grid is to represent 1,000 people. So there's 500 squares, each square represents 2 people. Now, that little red square there represents childhood hearing loss. There are 2 to 3 children per 1,000 who have a hearing loss. Now, this number at first glance might seem very small, so I think an analogy is really helpful on this to really understand its impact, because it's actually not a small number when it comes to newborn screenings or newborn disabilities, chronic disease. So 2 to 3 per 1,000 is actually the number of physicians in the United States. So certainly, you know many physicians, right? You're aware of many physicians, but you're not quite as aware of childhood hearing loss because it's an invisible disability. So that was a very helpful number for me in reference. Childhood hearing loss from a public health perspective has made great strides in the last 2 decades. So there's something called EDI, the Early Hearing Detection and Intervention program, where hearing loss is considered a developmental emergency. And that means it's very critical in those first early months to years of a child's life that they have access to sound in order to have neural development proceed well. And access to sound or access to language. So if someone has exposure to sign language, then their brain development would proceed accordingly. However, the issue with childhood hearing loss is often about over 90% of children with hearing loss are born to hearing parents, so they don't necessarily have exposure to sign language. So the issue with childhood hearing is we have this 1-3-6 rule. So we want to have a universal newborn screening by 1 month, a diagnostic evaluation by 3 months, and treatment by 6 months. Now, these numbers are quite important. This is the number of children lost to follow-up. So in Arizona, it's very amazing to me. It's a state we don't actually mandate newborn hearing screening, but we do very well in accomplishing the screenings. We have over 98 to 99% every year of children who are actually screened within the first month. The issue becomes children who go from screening then to diagnostics. And we have about 50% of kids who are not getting to a diagnostic appointment. The story used to be a little bit worse. In 2008, the numbers were 73% of children were lost to follow-up. 2012, there was improvement of about 20%, but still as a state, we can do better. And a remarkable accomplishment has been really specifically to screenings happening in the NICU, where in 2008, about 75% of NICU babies who are at a higher risk of hearing loss were lost to follow-up. Now, in 2012, through some great efforts in the state, that number is down to just 12%. So it is possible to do better. And within our department, one of the barriers that we've identified for children being lost to follow-up is not having funding for the diagnostic evaluation or the intervention process. And so the Children's Hearing Fund was created in the hearing clinic to try to reduce barriers to diagnosis and intervention for childhood hearing loss. So hopefully when the next numbers come out, let's say in 5 or 10 years in our state, that we can get that number lost to follow-up way, way down, let's say 0. So I'd like to give a special thanks to the Cruz family, who was very influential in helping to create this fund in our department. So let's come back to our big grid. So that was about childhood hearing loss from a public health perspective, and so we've accomplished a lot. Now let's think about adulthood. And remember, there were many more claps that happened from the audience about adult hearing loss. So try to predict. How many adults over age 70 have hearing loss per 1,000? So take a minute, think of your number, tell your communication partner. Okay, and now for the big reveal. 667. This is a remarkable number. It really motivates my research, and I think that studying development in childhood, it's equally important to study our development throughout our life course, okay? The population is aging, of course, but we also have far greater life expectancy now than we ever had before. So someone at age 70 has the capacity now to live 20 or 30 more years, right? So how many of these adults over age 70 are seeking care for their hearing? Take a guess on that. 1/3, I heard. It's a little bit lower than that. It's about 20%. So to me, this illustrates a very big gap in care. And this is really, we're entering uncharted territory as a nation, where there's a quote from a book, 60 on Up, The Truth About Aging in America. All of us are now in uncharted territory, a stage of life not seen before in human history. And whether woman or man, whether working class or professional, we are all wondering how we'll live, what we'll do, who we'll be for the next 20 or 30 years. So my charge to the community here in Tucson, in Arizona, as a nation, is really to start viewing adult hearing loss as a public health concern. So let's think about the issues related to hearing loss and aging. So here's an illustration of a piano keyboard and a bird. So let's see if I can whistle like a cardinal. High frequency sweep, right? Little chirps. They do up sweeps, they do down sweeps, but it's about 2,000 to 8,000 hertz. That's about the upper 2 octaves on a piano keyboard, okay? With age-related hearing loss, what happens is the audibility decreases, but also there's a change in our processing of the sound. So there's increased distortion. So what that means, if you were doing either the bird analogy, looking at that, or the piano keyboard, it's like having distortion or bad keys on the upper portion of your piano, right? And then as the severity of hearing loss increases, there can either be more distortion in those frequencies or even further down into the lower frequencies, causing major disruption of our sound perception. This has complex effects. It used to be the case that we only really thought about hearing as an ear issue, right? You learned about the pinna. Now we view hearing as an issue between the ear and the brain and the connections there. So complex effects happen with hearing loss in aging. Often there's tinnitus. Any claps for tinnitus? That's ironic, I guess. But a huge issue, tinnitus with hearing loss. And the issue also becomes hearing but not understanding. So with high frequency hearing loss, up there, the word with the blanks, the vowels might get through. You may know someone is talking, but picking up the exact consonants may be difficult. So something like science cafe with the high frequency S sound, the high frequency F sound can be very difficult to process. So hearing but not understanding, also changes in spectral processing, temporal processing, and neural processing, problems in background noise, communication breakdowns that happen, and with very recent epidemiologic studies in the last about 5 years, we've started to see connections between hearing loss in aging, depression, social isolation, risk of falls, and potentially a link with cognitive decline. So for all of these reasons, I would really like to communicate hearing loss as a public health priority. Over 48 million Americans have hearing loss. This shows you by decade, from teenage years all the way up into the 80s. The blue is for bilateral hearing loss, also important to consider unilateral hearing loss, which can affect quality of life. So it increases over the life course, and the estimated proportion of population increases from about 10% in the 5th decade through over 75% in the 8th decade. And new numbers were recently released from the World Health Organization, March 3rd. 1.1 billion people are at risk of hearing loss in the world. So hopefully I've convinced you all that hearing loss in adults should be viewed as a public health concern. Any claps for that? Good. Now, amazingly, this year will be the first time that a question about hearing will be on an Arizona public health survey. Now, this survey has been funded by the Centers for Disease Control for the last 30 years, and it's our state's major way, and many other states' major way of tracking health issues and risk factors and when health concerns go together. How do we track health disparities if we don't ask questions? Now, the concern about this has always been that it's a telephone-based survey. So first, if you get a call, you'll get a letter first notifying you, but you got to answer the phone. And the second thing is don't hang up, right? Because if you have hearing loss and are having difficulty on the phone, it's common to hang up, right? But I want to fight this battle because if questions about hearing do not become incorporated into our public health survey, that means that the survey is not reaching the community of people living with hearing loss. And as you just saw from those numbers, that can be a remarkably large set of our older population. So we need to know about the links between hearing loss and falls and hearing loss and Alzheimer's disease, but we won't know unless we ask the question. So I squirreled away money that I had left over from budgets that came in under, projects that came in under budget this year, and came up with the $5,000 to add a question to this survey. I could only get one question, so I could only afford one. But hopefully next year with this pilot data, we'll be able to move forward with additional looks. And we'll see how it goes. But importantly, it's also the first time accommodations are available, including someone reporting for the person with hearing loss or video relay. The CDC is allowing for that. So that's very exciting, I think. So public health view on aging and hearing. My view is more birthdays are better. The more birthdays, the better, right? Yes. We know that hearing changes may accompany with that. And so the point is we need to stay engaged for these last very meaningful decades of our lives. So that's what I'm going to talk to you about next, is how our research is looking at finding new ways to help more enjoy life, and we're working with and for our older adults in this endeavor. So for our research in the lab, just give you a quick snapshot. It might be too quick, so if it's too quick, ask me questions in the end. So this study is related to the fact that even when someone gets a hearing aid, So we have that set of people who get a hearing aid. A major frustration and even a deterrent to some people to accessing devices is that people continue to have difficulty understanding speech in background noise. It affects actually 90% of hearing aid users on customer satisfaction surveys. That's a huge number of people, almost 8 million people. So let's think about why that might be. So I showed you the birds. So with hearing loss, right, you have the decrease in audibility and also the distortion. What the hearing aid does is increase the audibility, but it can't alter the distortion. And that distortion has major consequences, including reduced intelligibility and making it just more effortful to listen. So we got together in the lab thinking about this. What is this issue with listening effort? Every time I do a talk or I am in a group, people talk about the issues related to listening effort. It's possible that some of you, if you have hearing loss tonight, after listening in this environment for an hour, will need to rest because it's fatiguing, right, to listen. So what is that about? Well, we're thinking it can't only be about the intelligibility because there just has to be more to it than that. We should be addressing things with audibility. So what else is there? Well, I talked to you briefly that we've started to identify many top-down connections and neural connections. So our question with this study was, how does this distortion affect our working memory for speech? So not just how well you can understand the speech, but how well can you remember it? How well can you do things with this speech? So even in cases where you can still understand. So talking about working memory in background noise, that's what this study is. We had 2 different tasks. The first one we'll call subtract to span. So you'd hear a list of numbers, say 4, 2, 6. Your job as the listener would be to remember that series of numbers and repeat it back after subtracting 2. So you'd hear 4, 2, 6. Now you say back 2, 0, 4. The second task was alphabet span. So you'd hear lake, pad, bat, some words. Now you need to reorganize them, remember them, and alphabetize them and say them back in alphabetical order. So from lake, pad, bat to bat, lake, pad. So we thought, well, we think we would predict, based on these distortion issues, that even young normal hearing listeners would have trouble in background noise on these tasks. But maybe less of an issue on subtract to span because it's always just numbers, this closed set of numbers. But on alphabet span, it could be any word. So that's just a huge range of words that could potentially, you could misunderstand in the noise. So let's take really quickly a look at the results. But first, let me tell you what the noise was. We used something called speech-shaped noise. And how you make speech-shaped noise, it's like static noise on your radio. So, psh, right? You turn to a channel that isn't really there. So you take white noise and then shape it with the spectrum for speech. So that's what people were listening to. So this kind of psh at the same time as either the numbers or the words. So let's first look at the results for working memory in quiet. So these are the results for just a small set of numbers. So you just hear 2 or 3 numbers, like 3, 5. People were really, really good at subtracting 2 from those and telling them back. So what do you predict happens when we make the series of numbers longer? Dun, dun, dun. Right, your performance declines. Though not by that much. People were still very good, about 80% correct in quiet for the large set size. Now if we look at alphabet span, so we have a small set of words, just lake, bat. Now alphabetize them, bat, lake. People again did really, really well, 100% correct. But when we made that list longer, very hard to do. So performance dropped to about 50 to 60% correct. So these are the results for performance in quiet. I'm going to leave these blue bars there as your anchors so you know what happened in quiet. And now let's take a look at the results in noise. So remember our prediction was that noise would be bad for everything. Distortion is bad everywhere all the time. A noise is a noise is a noise, and a noise is bad. But when it came to subtract to span, we actually didn't see any differences. So the fact that we had this really small set, your brain has a limited set of information to work with, the fact that there's noise there wasn't a problem. So looking ahead to alphabet span, what happened? So these were the results in quiet. We even had problems for remembering just even 2 words in noise for the alphabet span and alphabetizing them. And performance really tanked for the long sets of items. So depending on the condition, people were doing between 5 to 50% worse in noise. And this is for situations, at least for the gray bars there, where recognition was still very, very good, like 95% correct in terms of understanding the speech. So what we joke about in the lab is that it gives us this illusion of competence, right? Because you think you're doing fine, because you're understanding the speech. But actually, you're not as able to process and remember it. So that for me was a eureka moment in the lab. And I think it has important implications. We'll do further follow-ups on it, but at minimum, for certain kind of tasks where you have these it's speech communication happening, or it could be anything that's said, we would say turn down the background noise for some better memory performance. And we're actually now recruiting adults with and without hearing loss for this study. So if you're interested, please talk to one of the students after the talk. So now let me give you a brief snapshot of our current research in the clinic. Take a sip of water here. Very briefly, I'm going to tell you about a couple of opportunities, again, for getting involved. The number one question I get when I do a talk such as this, or interact with a group, or really just interact with anyone who needs to get a hearing aid, is why do hearing aids cost so much? Right? Well, that's a very good question. And so since I have a lab, I want to look at that question in more detail. And so instead of just viewing it as a cost issue now, we've started framing it as a value question. So we've started a double-blind study comparing different levels of technology. And the levels of technology in a hearing aid, if you have a hearing aid, you're familiar with this, they really drive the cost from a basic level of technology through more advanced signal processing. And so we're doing a double-blind study that will compare different levels of technology. So people come and listen in the sound booth, then go home for 2 weeks with a set of hearing aids, try them out, tell us what they think, but we don't know what kind of technology it is, and the person doesn't know what kind of technology it is. Come back, switch them out, go again. So this happens for 6 weeks. And we had some pilot funding for this from a very kind community member who said, Nicole, I want you to do the study that you've been dying to do. And this is the study I've been dying to do because it's everyone's question. We had some hearing aids that were donated by a company. So those are the hearing aids involved in the study. And so if you'd like to participate in that trial, talk to one of us after the talk. I wanted to tell you a little bit also about the Pima County Hearing Aid Bank, the Sertoma Pima County Hearing Aid Bank. About 7 fittings happen per month with this program, and it involves fitting, kind of like the Lions Club does with old glasses you might be familiar with, taking in donations from the community, repairing, refitting them, and then fitting them back to the public, so to low-income adults. And unfortunately, we haven't had quite enough donations of hearing aids of late, and so we just had to cut back from doing bilateral fittings to a unilateral fitting. So if you know of any hearing aids out there that could be donated for this program, please let us know. Another study we're working on is called the Cognition and Hearing Study. This is a collaboration with the Department of Psychology, and we're looking at how does hearing, cognition, and psychosocial health change with hearing aid or cochlear implant use. And we're just getting that project off the ground. So now let me tell you just a little more in detail about our Living Well with Hearing Loss groups, which we do quite a lot of research related to that program. What is a Living Well with Hearing Loss group? Has anyone attended a Living Well with Hearing Loss group in the audience? Thank you. I see 3 hands, so 3 claps. Great. So let me tell the rest of you what that is. So it's a group through our hearing clinic, and we've had over 500 people participate. About 3/4 of people attend with a communication partner, and over 80% of people attend all of the different sessions. 2/3 of the people who come have hearing aids, but about 1/3 do not. So let me give you a brief tour of the group content. The topics we cover in a discussion-based format include how we hear, types of hearing loss, the impact of hearing loss and hearing health professionals, the building blocks of communication, communication breakdowns, communication repair, and then also the psychosocial effects of hearing loss, all packed into currently 3-week groups. So 3 sessions on campus, 2 hours each time. So through this Living Well with Hearing Loss program, we've seen many, many people, and we always ask about how are you doing with your hearing? So we give formalized assessments of that to understand what it means to be living well with hearing loss or having difficulty living with hearing loss. So this figure is going to show you from mild hearing loss on the left through severe hearing loss on the right. And then the self-assessment of communication is a scale that we use to document how much disability a person experiences with hearing loss. So no disability at the bottom, all the way up through severe disability at the top. So these are results for about 130 people who've participated. And of course, there is a correlation between how much hearing loss a person has and whether they report mild to severe disability. But what I want to draw your attention to is, although we have this significant correlation, we have huge variability, particularly in this mild hearing loss range. So that red box is showing you mild hearing loss. So my other takeaway message from tonight, aside from viewing hearing loss as a public health concern, is really, do we really call it mild hearing loss? If someone has a threshold change that we call mild in the clinic, but they're actually reporting a severe effect on their life and their quality of life. So is it really mild hearing loss? It might be a bit of a misnomer. Our students are always very actively involved in our Living Well with Hearing Loss groups. All of our AUD students participate in their first semester of clinic and then follow up with a later clinic placement. And our students find this to be a very, very rewarding experience to learn from people experiencing hearing loss. And one comment that stood out to me from a third-year AUD student was that the participants taught me more than any textbook ever has. So it's hugely important to our students to offer this program as well. For group attendance, just about everyone calls it excellent. If you say it's good. The length of the course, everyone says it's just right, whether it's a 2-week, a 3-week, or a 5-week group. And people come back, and that's remarkable in the literature. This is a very, very high rate of attendance compared to other programs in the literature, which are normally around 40% of people attending all sessions. Again, groups are open to the public. I'm going to go briefly through that. This is interesting. Reasons for coming to group. Most of the time, there's a wide range of responses for people with hearing loss, but that gray bar there is the communication partners, and they're often not sure why they're there at group. Now let's look at outcomes in terms of quality of life. And remember that this is not a program that's device-oriented. This isn't about wearing a hearing aid. This is about learning communication strategies and experiencing support related to hearing loss. So in terms of quality of life, a handful of people have reported no change, but overall, 86% report some amount of improvement in quality of life. And that ranges from a lot of slightly better to quite a lot better to a few have reported very much better, just on the basis of this discussion-based group. And if you think about how much people use the strategies from group, this has been a very interesting thing to look at. So people come to classes and learn communication strategies. So what percentage do you think of people use those communication strategies on a daily basis? I need a slightly louder one. Okay, so the big reveal. Actually, 97% of people reported daily use of the strategies from the program. And I think that this is a remarkable number. And when I presented this at a conference, the audiologists in the room and some of the students who'd guessed, more like 40%, like, oh, wow. So it's very important, very meaningful. And looking at that from communication partners' standpoint, communication partners also report a very high amount of daily use of the strategies, 86%. Communication partner outcomes as well, 89% reporting some improvement in quality of life. Again, slightly better to quite a lot better. And it's very important to note that this is comparable to the amount of improvement that someone experiences when they get a hearing aid. So I think it's really critical to think about this as part of a holistic plan for somebody living with hearing loss. And one comment from a spouse was that this program saved our marriage. That took me back the first time I heard it. Now I'm like, oh yes, I know. If we ask people what the 3 most important things they learned in group are, list them all and then categorize them, it's the communication strategies that come out as the most important. Also just general information, like learning something about their hearing loss, and then experiencing support from other people. And so out on the table, out at the back, there's a colorful flyer that looks like this called Communication, a Two-Way Street. These are the highest rated strategies from our Living Well with Hearing Loss groups. So if you want a preview of Living Well with Hearing Loss, or need a refresher, or just want something colorful to put on the refrigerator, or need something to refer other communication partners who aren't here tonight to as strategies, that's available out at the table. So that transitions me to thinking about our current research in the community, because we have this very successful program on campus, right? And I've talked to you about how these results with this program are actually comparable to what someone reports in change in quality of life with getting a hearing aid. But in the community, and I should acknowledge my co-authors and of course, definitely the funding, we have NIH funding for this project, which is very exciting. So we're taking our hearing science on the road, and we go from Tucson to Nogales just about weekly to do this. So come with me now to Nogales. From Saddlebrook to Nogales, the issue, Saddlebrook compared to the rest of the United States, we're doing well in terms of median income and remarkably well in terms of education level. In Nogales, not quite as great a picture, where median income is about $26,000 compared to $65,000 here in Saddlebrook, and the number of people without a high school degree is about 40%. So these socioeconomic disparities translate into people having issues with hearing but not necessarily being able to do anything about it related to a device. Hearing aids are not covered by Arizona's Medicaid system, and beyond hearing aids, access to rehabilitation is often very limited because it frequently follows device fitting if it ever happens. And so our Living Well with Hearing Loss program is a new model of putting that first, so rehabilitation first, and empowering people in the process. So this is a summary. We looked first at about 80% of the population, general population, with untreated hearing loss. And if you look at those numbers for the Mexican-American population, it's about 96% with untreated hearing loss, if you're using hearing aids as the proxy for treatment. So this project is really looking at how can we address these huge gaps in access to care that we have, not only here in Arizona, the Grand Canyon state, but actually throughout the nation. And so our approach, we're really working with the community with hearing loss. It's an interdisciplinary project between public health, the Community Health Center in Nogales, audiology, and Spanish and Portuguese. And we're working with the Mariposa Community Health Center, which is the healthcare safety net for Santa Cruz County. And specifically, we're working with community health workers. And the community health worker model is an approach that's a public health approach to address health disparities. And who are community health workers, or promotoras in the Hispanic community? They're the frontline public health workers. So they're providing culturally appropriate health education and assisting the community in understanding and accessing the healthcare system. And a great quote from one of our promotoras on the project was, "The nurse's job is to support the doctor. Our job is to support the patient." And I can't tell you how many times working on this project, I thought, wow, I wish in my healthcare that I had someone advocating for me like this. Community health workers also facilitate research. They are a link between the university and the community, just like they are between the medical system and the community. And so our project is Oyendo Bien. We're looking at identifying the barriers and facilitators in access to care, working with the promotoras, and then culturally adapting the Living Well with Hearing Loss program from campus to meet the needs of this community. And then we're testing the effectiveness over the next 3 years of running promotor-led hearing health groups. So last year we spent doing a needs assessment. We interacted with 213 people, doing community hearing screenings, focus groups, patient interviews, family focus groups, and provider interviews to really zoom in and say, what are the issues related to hearing in this community, and what are the barriers in accessing hearing healthcare? And just quickly, the results from our community screenings: adults between the ages of 21 and 86 attended, and we had about a 70% referral rate, which is fairly high for doing a community screening. Looking at the results from our barriers and access to care, we had some very interesting differences between community members and the providers. So in the blue bars here, this is just representing the percentage of the total number of references to different topics. So topics like stigma, side effects, device issues, denial, cost, and the aging process. And you see the providers are really focused on this cost issue, even more so than we thought from the community. We thought both community and providers emphasized costs of care and the distance and travel burden from someone in Nogales accessing care in Green Valley or Tucson. But the picture of barriers was much more complex from the community than we heard from the providers. And a huge issue was that patients were feeling like they weren't getting the needed information or information that they needed from their physicians. And what we heard from the physicians about that was that physicians are unwilling to refer even for a hearing test if the person cannot afford the treatment of a hearing aid in the end. And providers were really only focused on hearing aids. So, okay, someone can't get a hearing aid, so someone shouldn't have a hearing test. Therefore, so that has consequences, right? But what I've just told you about with the Living Well with Hearing Loss program is communication strategies training can actually improve quality of life. So we're working on going from this situation where having many, many barriers and people not having access to care to one that's hopefully more positive. So back to the Grand Canyon analogy, the quote, "Many people assume, well, this is how I am and this is how I'll stay. We don't seek help, but the problem is serious." So going back to the beginning of my talk, thinking about how do we conceptualize healthy aging in America, we want to think about staying connected and people being engaged for 2 to 3 decades. Okay, so this is the Grand Canyon analogy of how people are feeling. People aren't feeling empowered, and people report that it would be a great help to have more information first. So our current healthcare system is a bit like putting people on the edge of a cliff, right? And hopefully you can make it to one of those rafts on your own, right? And one of those rafts is going to cost you $5,000, and another one's going to cost you less, but you don't really know if there's benefit for being in one raft versus another, right? That's scary, okay? So how do we address that? In thinking about forging the Grand Canyon, right, often we would do that in a group like living well with hearing loss, right? So you're empowering people with knowledge and skills and the social support of peers first before, attempting that big cliff. One of our students, Adriana Sanchez, has done deep work in the area of the effects of hearing loss on family and the impact of culture. Our community health workers prioritized 2 major needs for the adaptation of living well with hearing loss for the community. One was, again, this empowerment issue, so improving people's confidence there is something you can do about it beyond a hearing aid. And the second is improving communication in the family. And so we've worked very hard to prepare our promotoras to address hearing loss in this community, about 6 months of work on that. And really positive outcomes from this. And a really powerful quote to me about this is from Paulo Freire, whose work we cite and refer to quite often in working on the trainings. The act of participating in community change promotes empowerment. So just by participating in this research process, and by participating in the needs assessment and learning about hearing, it really empowers the community, increases resources that weren't there before. And our promotora said, I would like more classes and to learn more so that I can help my community. It's a topic that is not discussed, at least for promotoras. And it turns out perhaps not for other providers as well. So this is just a picture of our pilot intervention that's happening right now, every Wednesday. 5 weeks, 1 hour a week. It happens at senior housing. Our promotoras provide transportation for people who need it to get to the group, and it's facilitated by our trained promotoras. And again, it's addressing the different priorities from the needs assessment. So drawing from our Living Well with Hearing Loss curriculum, but adapting that for the community. And so it's going on right now. We've done baseline, and so group is in progress, and then we'll have 2-week post results and 3-month post results for our pilot. So a summary about the status quo versus our approach. The status quo is to give education and counseling after somebody gets a hearing aid, which can be a very device-centric approach and can cost quite a lot, and so can be a huge barrier to someone getting help that they need. And so our approach is to provide that education and counseling before amplification for self-management. The status quo, like that analogy to the Grand Canyon, is to navigate the complex system without support. And so this approach has culturally competent advocates to increase and facilitate access to the system. And then the status quo, again, is to focus only on the individual with the impairment. But what we've seen in Living Well with Hearing Loss and also through this project is that we really need a family-centered approach to hearing care, because hearing loss impacts not only the person with the hearing loss, but also their communication partner, so all members of the family. So my take-home messages for you tonight, put them in this nice little takeout box. Science to go. You have hearing is important across the lifespan in childhood and throughout adulthood. I would recommend reducing background noise for anyone to keep your working memory performance good. Help for hearing loss really does go beyond hearing aids. So if you hear that, that's a common misconception. Please help me to dispel this myth. And our current research is really focused on addressing these gaps in care. If you would like to get involved in any of this, you might consider volunteering for a research study or collecting used hearing aids for our hearing aid bank, or perhaps letting friends know about the Living Well with Hearing Loss groups. And really focusing again on staying engaged and keeping people in the conversation, keeping people involved. I don't like the stigma of the isolated elder. Ways to get help for hearing. We have a wonderful resource in the state called the Arizona Commission for the Deaf and Hard of Hearing. If you haven't heard of it or access their website, I encourage you to do that. If you're looking for help for hearing, I would say contact an audiologist and find peer support for it as well. That's what we've really learned from Living Well with Hearing Loss groups. And just sitting down at the dinner table, if you were asking me this question, well, how do you find someone? I would look at their training and qualifications, also your comfort level with the provider, because you'll be seeing them for multiple visits, their availability, how easy it is for you to access them. And I would also recommend finding a provider through a referral, so either a professional organization or word of mouth from someone. Peer support, we have wonderful peer support in the state of Arizona. We have our Living Well with Hearing Loss groups. There's also the Adult Loss of Hearing Association, which has been in existence in Tucson for over 30 years and is the longest continuously running peer support group. They have a weekly peer support group. They've added a daytime, an evening group. There's a group that meets here in Oro Valley. So check that out as well. And there's also statewide and nationwide, the Hearing Loss Association of America. Helpful reading. A couple of books. One that has recently been on the New York Times bestseller list is Shouting Won't Help. Right, it won't. Why I and 50 million other Americans can't hear you. And thank you all for coming.
Thank you so much. That's a really fantastic talk. We have 5 minutes for questions, and just thanks again. This work on bringing hearing loss as a public health issue and bridging this gap in disparities to access to hearing health care. Sir, please.
I get a lot of mail asking me to participate in hearing aid research, and I see advertisements in the newspaper for that. I've always assumed they're all scams.
I'm not a scam. I'm for real. This is real science. So that's where you need to be really aware and read carefully. And so look for what you would view as credible sources. A great resource, I think, for consumers is looking at the Consumer Reports Guide to Questions to Ask. It's unfortunate in our society that there are people who try to take advantage of this situation. And as we talked about, there are people who are really struggling and can't necessarily access the traditional healthcare system, so are looking for other options. So, just like today, I got a call, it's my final notice that if I don't act now, I'm going to miss this amazing opportunity to refinance my mortgage, right? That was unsolicited, but it really sounded scary and punishing on this message. So I think we have to be very aware of that, and I'm very protective of people when it comes to that, and I'm concerned in the community about claims that people make, and I hope that we can, help to distinguish between what's, absolutely helpful and what's a scam. But it's hard.
Sir, and then you, sir.
Wow, what an excellent question. So I very much appreciate your comment there, and I think that helps to build the case for viewing hearing as a public health issue, especially from a source like the World Health Organization. How do we define hearing loss? This is a huge question. Now, when it comes to public health, often the common definition is a threshold shift, so only looking at hearing acuity, sensitivity at usually the speech frequency range. So it depends on the study, which would be nice if we could come up as a scientific body about the absolute definition to use across studies, but it's often the speech frequency range between 500 and 4,000 hertz. But it varies across study, and so as we're looking at the epidemiologic data, we have to be careful to look at that. The data I was reporting to you comes from a very unique set of epidemiologic studies where it was not only self-report of hearing loss, but actually measured audiometric threshold change. So from those data, then we extrapolate to the rest of the population, and that was the first set of studies that had done that very recently. Thanks. This is where I go to the need for the study that we're conducting about the cost effectiveness issue. The question, sorry for anyone who couldn't hear, was there's $400 hearing aids and $5,000 hearing aids, and how can you know if you should get a $400 versus a $5,000 hearing aid? And it's a very good question. And I think it's important for each person to look at the needs that they have. So the communication needs, it's possible that someone does not, I don't think it's a heretic view in audiology. It's possible that someone does not need the $5,000 hearing aid. It's possible that someone needs, something that costs less. That's importantly how we train the students, is that needs to be a dialogue and shared decision-making between the patient and the audiologist. So it's not a one-size-fits-all. I can't say, yes, everybody would benefit from something that costs $400. Everybody would benefit from something that costs $5,000. I don't think we have that kind of data to say that, really, even.
We have time for, let's do one more question. Sir?
I'm just going to give some personal testimony. I've been going to the U of A for about the last 7 or 8 years. And participated as a patient. I've also participated in some of their studies, and I can tell you it's a top-notch organization, and you won't beat it. And one of the things that I think a lot of people think about when they go down there, where am I going to park?
Well, thank you.
Let me just answer that question.
I should have put a map.
When you go down there, number one, you're going to have a parking spot because you'll get a parking pass before you ever go down there. So it's not a big deal. You just go down there and you have a parking pass. There's a spot right before you're going to the door, and you go in. And you'll have a student, but you also have an instructor behind you that'll be watching the student and what they're doing. So I've been part of a lot for a long time, and I can't say enough about it. So,
thanks, Dick.
Thank you, sir. That's a great spot right now to just end the formal presentation. Let's have one more round of applause, please. It's great work.
Thank you.
We'd like to invite anybody who would like to come up with subsequent questions, come on up. And then we have Kathy Faye and some students from the department out front with lots of materials. And again, thank you so much for coming out. You'll be hearing from me for the April. We'll go back to Wednesday. This was an odd night, doing it on a Thursday. It'll be a Wednesday, but always at 6:30. Just so you all know, right here, exactly, at the Performing Arts, and I'll be in touch that week before with an update. Thank you so much, everybody. Good night.
And if anyone would like to make comments, we have an evaluation form outside as well. So if you'd like to leave any comments for me, I would love to hear them. Thank you.